a real pleasure to welcome back Matt Crystal to Toronto, his home stomping grounds. We're at the Toronto course for congenital structural interventions. Matt, welcome back.
Thanks, Eric. It's always a pleasure to be back.
Matt, are you as warm as I am under these lights?
Yeah, it's a little bit schwitzy now.
It's a little schwitzy.
It's a little moist.
So tell me, Matt, where are you working these days?
So I'm at Columbia Presbyterian, which is now the Children's Hospital of New York, Morgan Stanley Children's.
And you're a specialist in
pediatric cardiology, interventional cardiology, and I've now expanded to your side of the street, and I'm doing a fair number of adult congenital interventions as well.
Many years ago, decades in fact, Matt was a fellow of ours in Toronto, and it's nice to see that he's gone on to the big city to stamp out disease everywhere. What are you going to be talking about at the Toronto course?
Talking about coarctation of the aorta and how to manage it from consultation through to completion.
If you could give me an idea when you see somebody with coarctation, what your clinical evaluation is, or how do you approach the patient? Like, what questions are really important for you? What do you want to do in that initial consultation?
So I think a lot of that depends on the age of the patient. Many of the children that we're taking care of, we see them as infants, and some of them come later in childhood. Most of them are asymptomatic. What they come to us with is an incidental finding of hypertension on a routine follow-up, and renal ultrasound is normal, and all of a sudden somebody feels a pulse, it's weak in the femorals, or it's more to do with the clinical findings of then a blood pressure gradient. It's atypical for us to have a critically ill patient the way you would see in some of the adults that get cared for.
And what are the types of investigations you're looking for before you actually go to the lab? Are you going to be satisfied with an echocardiogram alone, or are you going to do anything else?
So again, in children, the imaging quality is much simpler. There's less tissue to get through, and we have a really nice image. And for many cases, the blood pressure gradient and the aortic arch may be enough. I think in the last number of years, I've certainly changed my practice somewhat to do more MRI or CT to really get a better understanding, considering the significant diversity we're now starting to see in the patients with coarctation.
And what do you tell the parents about risk, about what to expect, or what are the possible things that can happen during the procedure? Like, what's a reasonable discussion with the parents?
So again, some of that will be dependent on what we know about their aortic arch anatomy from the non-invasive imaging ahead of time. In the very complex arches, atretic arches, where you're going to have to be very aggressive with perforation and things, we then talk about a much higher risk, potential for perforation, potential for dissection, potential need for surgical backup and intervention. For the other ones that are more routine, it's more so a discussion about the stent not sitting exactly where you want it and having stent malposition. And I talk about some of the potential risks, but in that patient population, I usually am discussing that's not quite the same context, not quite the same severity.
Where do you rank coarctation stenting in terms of complexity for a routine coarctation, not something that involves a hypoplastic arch? We'll come back to that. But where do you rank in your own head? Like, how concerned are you when you actually set out to do a coarctation?
So, my process since I've moved to the U.S. about a decade ago has really changed. I was trained here by you and by Lee with the covered stent, and the approach was you go in, you put in a covered stent, and a number of the other issues you don't have to be as concerned about. I then moved to the United States, did not have the covered stent, and had to unlearn the strategy and the philosophy that was used with the covered stent, and it's now come back to that, where for a lot of the cases you're going straight forward, you're able to do it with the one stenting, you're not having to do the strategic 2 or 3 dilations to get there. So I think that some of the risks and some of the approach has made it a simpler procedure in the less complex arches. The more complex arches, I think that at this point, I've learned that sometimes the better you can be is going to be the most creative and the most collaborative with surgeons, new techniques, new devices that aren't always what we use in our congenital cath lab, and that's where in the last number of cases, I've taken a lot of extensions with my vascular surgical colleagues, my cardiac surgical colleagues, to get a different different approach on how to address these really complex arches, and that's where now the challenge comes from.
Yeah, I really think the point you bring up is a good one because, no matter what your feelings are about heart teams and how heart teams work together, it's very hard to get away from the notion that we actually provide better care when we actually collaborate with different specialties, and you just can't get away from it in medicine. It's just a reality of our practice today in large academic centers. Tell me, in terms of the thing or how long have coverage stents been available in the United States?
So when I first moved, the coverage stents were strictly on trial, and then there was a number of the centers that had to go through the initial Cheatham Platinum stent uncovered, and those had to be used. You had to balloon test
Coast trial.
the Coast 1.
Coast
so you're
1.
doing that, and you had to go and balloon dilate and hope you didn't tear, but you had it on the shelf just in case.
Right.
Once that was approved, we finally then started moving into the actual approval, and it's only been a few years that the FDA has given free approval to any center to have it on the shelf. And to me, that's something that every center that does coarct stenting or any stenting should have it on the shelf. And with the newer sizes, I think it's an absolute must.
And are the coverage stents only approved for coarctation, or can you use that in a conduit as well if you need to?
So since the Parks trial, which was the coverage stent in the PA reconstruction trial, that's now gone through, you can now use it in both the conduits and in the coverage stents. But certainly one of the issues that happens in the United States is things get used that once they're FDA approved, they get used off-label, and as long as you state that it's off-label for many of the devices that we use, that's where the baseline is, as there's already no approved stent for pulmonary artery interventions, for example.
So, the bane of our existence in coarctation is really, I really think there's two things. Number one is a patient who has poor access, which I don't really want to talk about because I don't think there's a great solution for those patients. And the second is people who have arch hypoplasia in addition to an isthmic tight coarctation. So if you have a 30 millimeter gradient at an isthmic coarctation and you have a diffusely small arch, like in an adult I would say is 14, 15 millimeters, what's your approach to that? Are you stenting the arch, a hypoplastic arch? Are you doing a hybrid? Are you trying to stent the isthmic coarctation and seeing what happens? I'd be interested to hear what you're doing.
So I think I'm lucky I work with exceptional world-class surgeons who are incredibly collaborative, and many patients that I do stenting in the cath lab of the cohorts are actually referred to me by my surgical colleagues. So when it comes to a very complex arch, especially in a child who does not have all the comorbidities, having them go in and do an repair where I may never need to do anything else, and if we do, it ends up being a stent down the road for potential issues, I have no problem referring to them for many. It's the ones that I think aren't that 14 millimeter one, it's the 16 or 17 millimeter where you don't know how it's going to respond, and after you open the isthmus, it becomes smaller. I think for those, if you have a very displaced left subclavian and you have a lot of room to put in another stent, you can stent the whole arch, considered an open cell stent, cross and jail intentionally the left subclavian, stent through the side cells, and if you need to come in with some other coarct stent that's covered in the isthmic region, you can approach both almost separately, but with a longer open cell stent first to set the stage. But like I said, for a lot of these, it's always a discussion with our surgical colleagues to see what is the best approach for now, the future, with the least risk.
So let me ask you a question, Matt. We call this the only course directed towards early career professionals. Give me 3 take-home messages or 3 of Matt's rules to do a coarctation safely. Give me your 3 take-home messages so that our audience is most interested in from an experienced operator.
So that's an interesting question. I think that number one, like I said, I think you have to have coverage stents on the shelf. You have to be familiar with the coverage stents, and you also have to be familiar with other types of devices that you may need that are beyond the CP coverage stent.
Matt, this is the only course directed at early career interventional cardiologists. And really what I want from you is your 3 main messages from an experienced operator, big center, about how to do coarctation safely and well. So what would you say?
So I think that the number one is you have to have covered stents, and you have to be familiar with the covered stents. You have to understand how the Gore-Tex works, how it's going to move, where the tips need to be, so you don't jail other things, but you can do the aggressive coarctations and open them safely. I think you have to know when and how to pace effectively for the coarts that are not super tight, and missing with the stent is also very important.
Yep.
A very, very tight cohort, the stent isn't going to move. It's much more easy to hit that point, and I think that understanding when to pace. And the third thing that is also going to be imaging, imaging, imaging. The better you plan what you're going to do, the better your outcome is going to be. So get your lay of the land, get the imaging, take your time, have the right equipment, and know how to deliver it in a safe and effective, efficient way that you possibly can.
Matt, that was amazing. Thank you very much. I look forward to tomorrow and hearing that lecture.
Thanks, buddy.